Welcome back to the Deep Dive. Today we're tackling something that, on the surface, might seem a bit dense. It's a critique from the European Journal of Radiology.
But the insights are incredibly high impact.
Absolutely. The mission here is to understand a fundamental argument these authors are making, that the entire system for classifying breast cancer is, well, broken.
Confusing, at the very least. And they argue it's actually hurting patients.
So what is this core problem?
Well, it's about the names we use. For years, cancers have been called ductal or lobular, but those terms are based on what the cells look like under a microscope.
The cytology.
Exactly, the cytology. It has nothing to do with where the cancer actually starts, the anatomy.
And that confusion, that disconnect, has real-world consequences for how patients are treated.
It really does. So this whole dive is about getting back to the anatomical source, the starting point.
Which is a structure called the terminal ductal lobular unit.
The TDLU, right.
Yeah.
And using what the authors call imaging biomarkers to fix this whole naming mess right from the start.
Okay, let's start there. The TDLU. What is it, and why is it so important?
So you have to picture something incredibly small. The normal TDLU is maybe 1 to 2 millimeters. That's it.
The size of a pinhead.
Barely. And it's made up of the very end of a duct and a little cluster of sacs, maybe 40 to 120 of them, called acini.
Like a tiny bunch of grapes.
That's a perfect analogy. And here's the kicker. Nearly everything in the breast, benign or malignant, starts right there. Fibroadenomas, cysts, all of it.
So it's the biological epicenter. And the paper's main finding is what?
That about 75% of all breast cancers originate in that tiny TDLU.
75%. And yet pathology reports are still calling them ductal or lobular.
Right. It's a huge anatomical inconsistency. It just makes no sense.
So what's the proposed solution? A new name.
A new anatomically correct name. For that 75% that start in the TDLUs, they propose calling them acinar adenocarcinoma of the breast.
Or AAB for short.
AAB. The acinar part points directly to those little grape-like acini. It's a name based on structure, which, is already the standard for prostate cancer, for salivary gland cancer.
It seems logical. So what about the other 25%? The ones that don't start there?
Those are the ones that actually start in the major milk ducts, the lactiferous ducts. And for those, the name should be ductal adenocarcinoma of the breast, or DAB.
AB and DAB. Simple, clear.
And critically different. When you lump them all together under ductal, you lose all predictive power. You're mixing apples and, oranges that are far more aggressive.
So why is the old system so entrenched? The paper points to a specific biomarker, right? E-cadherin.
Yes, and this is where it gets really interesting. Pathologists use E-cadherin to make the call. If the cells have it, they're called ductal. If they don't, they're called lobular.
And the paper's critique is that this is a logical flaw.
A major one. They argue that having E-cadherin doesn't prove the cancer started in a major duct. It's just a feature of the cell. It's confusing correlation with causation.
I think we need that analogy you used before we started, the one about the runners.
Right. So imagine you're trying to figure out where a marathon started. The current system is like looking at the runner's shoes.
Okay.
It says, these runners are wearing these elite carbon-plated shoes, so they must have started at the Boston Marathon.
But lots of runners wear those shoes.
Exactly. The shoes just tell you they're serious runners. They don't tell you if they started at the Boston Marathon, the major duct, or at a small local 10K, the TDLU.
The biomarker is the shoe, not the starting line.
Precisely. And the anatomy, the actual tissue, clearly shows a different starting line.
That makes perfect sense. So this brings us to the next big step. If we can't rely on that one biomarker, how do we make this distinction early on, before surgery?
The answer is imaging, what you can see on the mammogram.
The imaging biomarkers.
Yes. Decades of data have allowed researchers to connect specific visual patterns on a mammogram directly to the cancer's origin. Cancers from the TDLU, or AABs, have 4 very specific looks.
Let's walk through them, starting with the earliest stage when the cancer is still contained. In situ, what do we see?
We see calcifications, but it's crucial to know there are different grades. Grade 1, in situ AAB, looks like clusters of really fine specks. The paper calls them powdery or cotton ball-like calcifications.
Powdery, like someone dusted it with sugar.
A good way to put it. They're actually tiny semoma body-like crystals floating in fluid inside the TDLU. This type is very slow-growing, makes up to about 18% of malignant calcifications.
Okay, so that's grade 1. What about the next step up, grade 2?
The look changes completely. For grade 2 in situ AB, the calcifications are much coarser. They're described as crust stone-like.
That sounds much more aggressive.
It is. It's a sign of more rapid growth. Those little stones are forming in necrotic debris in dead tissue at the center of the cancer. This is the more common one, about 52% of malignant calcifications.
The visual difference between powdered sugar and crushed stone tells you so much about prognosis right away.
A huge amount.
So that's cancer that's still contained. What happens when it breaks out becomes invasive AAB. The biomarker changes from specks to, what, a solid mass.
Exactly. It forms a mass. And invasive AABs show up in one of two ways. You either get stellate or spiculated
A
masses.
spiky star-shaped one.
Right. Or you get circular or oval-shaped masses, which are more rounded, smoother.
And I remember the source showed an image series, years of screening exams, where you could literally watch the calcifications evolve and then a spiculated mass form right in that spot.
It's undeniable proof of the process. You're watching it happen. And this is where it gets really practical because the shape itself tells you about the prognosis.
A spiky one is different from a round one, even if they're the same size.
A world of difference.
Yeah,
The stellate, the spiky tumors, they generally have a better prognosis.
and the round ones.
The circular or oval tumors, for the same size, have a significantly higher rate of all the bad stuff, the unfavorable biomarkers.
What are we talking about? Grade 3 tumors, triple negative.
All of the above. Compared to the spiky ones, the round AABs are over 4 times more likely to be grade 3, over 4 times more likely to be ER negative, and over 4 times more likely to be triple negative.
Wow. So the radiologist sees that round shape and immediately knows this is likely a much more aggressive cancer.
Instantly. It's providing information that pathology sometimes only confirms much later in the process.
Which brings us to the clinical impact, the so what for the patient. How does adopting this AAB and DAB system and using these imaging biomarkers actually change treatment?
Well, it makes the prognosis far more accurate. We know that AABs, the ones from the TDLU, have a good to excellent long-term outcome if you catch them early, under 15 millimeters.
And that's the success story of screening, right? Finding those early ABs.
It is. That's where the massive mortality reduction has come from. But if we're misclassifying them, we risk getting the treatment wrong.
In what way? Overtreatment.
Overtreatment is a huge one because a small AAB gets called ductal, which sounds aggressive. Many women are subsequently overtreated with therapies they may not have needed.
And the flip side of that coin must be undertreatment.
And that's even more dangerous. This happens when a small AAB is hiding an associated, more aggressive DAB, the real ductal cancer.
The occult DAB.
Right, and those patients are often undertreated because the main tumor looks small and manageable. But DAB is the killer, with about a 30% fatality rate.
So how do the imaging biomarkers flag that hidden danger?
This is where imaging is just superior. That aggressive DAB subtype has its own visual cue on the mammogram, a very specific type of calcification called casting type.
Which looks different from the powdery or crushed stone types from AAB.
Totally different. And when a radiologist sees those casting calcifications, it's a huge red flag.
What does that do to the patient's long-term survival?
It's devastating. The data is shocking. Women with a small 114 millimeter AAB that also had those casting type calcifications, their 39-year cumulative survival was only 68%.
Compared to what for ABs without them?
Excellent long-term survival. So you have a situation where the standard pathology report, based on size and grade, might miss the risk, but the mammogram, the image itself, predicted the poor outcome. It's a powerful argument. The visual features have to be part of the primary diagnosis.
Okay, let's pivot to the second major flaw the paper highlights. This isn't about naming, but about staging. The T&M classification system.
The global standard, it's used everywhere, but it has a massive blind spot.
Which is what?
It's that it completely ignores how the cancer is distributed in the breast.
You mean whether it's one spot or many spots?
Exactly. Cancers aren't all neat little blobs. About a third are unifocal one spot, but another third are multifocal many spots, and a third are diffuse spread all over.
And the T&M system only measures.
The diameter of the single largest invasive focus. That's it.
Why is that so dangerous? It seems like an incredible oversimplification.
It is, because it consistently underestimates the true tumor burden, the total amount of cancer in the breast. You could have one 10 millimeter spot, and that's a T1 tumor, good prognosis.
Right.
But you could also have that same 10 millimeter spot alongside 20 other smaller spots scattered around. The T&M system calls them both T1, but they are not the same disease.
Not even close. What are the actual clinical consequences of that underestimation?
They're severe. For multifocal tumors, the risk of the cancer getting into lymph vessels and spreading to the lymph nodes is roughly twice as high as for a unifocal tumor of the same T size.
Double the risk of metastasis, because the total volume of cancer is what matters.
Of course, not just the size of the biggest piece. And then there's recurrence.
Let me guess, it's higher.
About 4 times higher for multifocal and diffuse cancers compared to unifocal ones.
4 times. So you're putting a patient with a 4 times higher recurrence risk in the same bucket as a patient with an excellent outcome.
You are. And you're giving that patient and their doctor an unrealistically optimistic prognosis.
And it messes up all the research, too.
It completely compromises the validity of therapeutic guidelines. If your data lumps these wildly different groups together, your conclusions are going to be flawed. The full extent of the disease has to be part of the equation.
So for you, our listener, what is the big takeaway here? It feels like we need to correct 2 fundamental things.
That's right. First, we need accurate names based on where the cancer starts. AAB for the common TDLU cancers, DAB for the aggressive major duct cancers.
I'm second.
Second, we have to stop using incomplete measurements. We have to look at the spatial pattern. Is it 1 spot or is it 20? Because that tells you more about long-term survival than many of the old factors we used to rely on.
It's like the era of early detection has shown us the cracks in the old systems. We're finding things so early that our old language just doesn't work anymore.
It doesn't. We have to integrate the highly prognostic information we can see with our eyes, the imaging biomarkers, the shape, the calcifications, right into the diagnosis from day 1.
Which leads us to our final provocative thought for you to take away. If the size of the single largest cancer focus is what dictates treatment in our universal classification system, but the total extent and distribution of the cancer is what actually determines survival.
What other crucial medical classifications for other diseases are currently relying on an incomplete measurement?